This next case describes rescue internal carotid artery stenting after a complication following endarterectomy. This is an important skill, as some endarterectomies may be fraught with complications such as flap or occlusion. In this case, a 68-year-old male presented to the emergency room. CT scan showed left frontal infarction and severe left ICA stenosis. He underwent endarterectomy for he had a symptomatic ICA stenosis with elevated Dopplers. As you can see by the CT scan and CT angiogram, he has a small infarct in the left frontal lobe, as well as a calcified, highly stenotic lesion of the left internal carotid artery. This is confirmed on angiography, showing a highly stenotic, calcified lesion. The lesion is relatively low at the level of C4 and is favorable for endarterectomy. After elective endarterectomy, and immediately after the procedure, the patient became aphasic. He was found to have a semi-occlusive intimal flap at the left internal carotid artery, and therefore was taken immediately for emergent rescue with endovascular stenting. His CT perfusion shows a significant area at risk based on elevated time to peak. Here you can see the flap on CT angiogram as delineated by the red arrow. After transfemoral access is obtained, we bring the guide into the aorta and into the left common carotid artery. Once we have left common carotid artery access, we change the planes, and under magnification angiography, we assess the intimal flap, or the occlusion. Here we can see a partially occlusive flap just distal to the carotid artery bulb. There still is significant intracranial filling. However, the stenosis from this flap is critical. We can see that we're struggling to get through with a microwire, but eventually find the true lumen, and we're able to advance a microwire into the distal internal carotid artery, followed by a stent. Here you can see a stent coming over an 014 wire. Once the stent is across the flap into normal internal carotid artery and normal common carotid artery, we begin to deploy the stent by unsheathing the self-expanding nitinol stent. We have to be careful to size the stent appropriately, as there is a fresh suture line as this patient just underwent endarterectomy. We can see by both the cervical and intracranial imaging that there is excellent resolution of the intimal flap and excellent filling of the cerebral circulation. This concludes the case of stent rescue following a complication from endarterectomy.